Thank you to the organizer for the invitation to this meeting, and congratulations on having adapted so well to the new circumstances. I mean, this was a great effort. So I always like to start from this graph here. These are data from the Eurostat for women in the UK, but it's very applicable to men, and I think is representative of data in the Western world. As we know, life expectancy has been increasing in the UK for women in the last 10 years. We have gained 2 years of life. However, if we look at the data at the bottom line here, you can see that diseases that present a number of years spent in good health, and they have not really changed in the last 10 years. If anything, have been decreased. This suggests that the 2 years spent, the 2 years extra life, are spent actually with disease. And when we look, the number of years at the moment in the UK that people spend in disease is about 12 years. And when we look at, what those diseases are, we can see complex medical needs. More than 50% of those aged over 65 have multimorbidity, so more than one disease at the same time. And if we look in those aged over 80, what is the fastest growing segment of the population, over 20% have more than 4 diseases, and 25 to 50% have frailty, which we define as an accumulation of deficits and loss of resilience. So the resilience is particularly in response to an adverse event, let's say a fall, an infection. Older people are less likely to recover. Multimorbidity and frailty are the major cause of service use, so 70% of GP visits are for multimorbidity, and patients with frailty cost double than those without frailty of similar age. So these are really the most costly areas and the one that have major impact on quality of life. So for us, multimorbidity and frailty are the biggest problem to tackle. And it's important because if we tackle multimorbidity and frailty, we can improve healthy lifespan. And the European Commission has predicted that every year spending good health is worth 0.3% of GDP. So it's real money. So what's the problem at the moment? The problem is that we view medicine, whether we do research or we take care of patients, as in the prism of a single disease. Cancer, osteoarthritis, osteoporosis, but that's not the reality in the patients. And therefore, patients tend to go to specialists, whether it's endocrinologists, cardiologists, and so on, and every one of them will give them a different set of pills. And very quickly, they will grow into polypharmacy. And we don't really know what polypharmacy is actually doing because most clinical trials use a group of patients that have possibly one disease. Surely multimorbidity and frailty are underrepresented. Most of the time they are excluded from trial, and despite being major users of the drugs afterwards. And therefore, and usually they also don't have any additional drug or very limited number of drugs. But if we, for example, look at this study from Sarah Hillner and Susan Howlett, they have tested 5 very commonly used drugs, and they've given it to young and old mice, and they've given it for 2 weeks, and then assessed a number of parameters like mobility, neuromuscular function, so balance, blood pressure, grip strength. And as you can see here, in the young mice, nothing really happens. They are both okay. But the mice that were treated with the polypharmacy in their old age, this is sort of how much has slowed down the locomotion. So you can see that they slow down considerably in the mice with polypharmacy. Similarly, this is the time they can balance, and you can see that the time is much less. And this is the amount of blood pressure that's increased despite they're taking tablets with blood pressure, for blood pressure. So really there are harmful effects of polypharmacy, suggesting that we really need to think whether we want to associate many drugs together or whether we want to find solutions that reduce polypharmacy. And we think that the aging field is really evolved in the last 5 to 10 years and can give some really good opportunities and solutions. So this is the model that with Mouse Age we propose and how we understand the relationship between cellular aging and multimorbidity and frailty. So we know that with age, at the cellular level, there are changes, dysregulation of mechanisms such as autophagy, DNA damage repair. And when the cells reach a certain accumulation, for example, of DNA damage, it sort of evolves into enters senescence, which is a state of cell cycle arrest. However, the cell is still alive and secreting a lot of pro-inflammatory factor and tissue remodeling factor. So you have also increased inflammation. And all of these impact on tissue function. So you start seeing tissue dysfunction, which when accumulated a certain threshold evolve into frailty, so an accumulation of deficits, but also predisposed to the onset of disease. We don't really understand this passage. I mean, all of us with age undergo a certain level of tissue dysfunction. I always say, I'm sure my cartilage is no longer what it used to be when I was 20, but I don't have osteoarthritis. And so something else has probably to intervene. We don't really understand. But we know that once we get the first disease, the second and the third will come much faster, suggesting that there is a link between them. And then they evolve to multimorbidity. And indeed, if we intervene, for example, if we eliminate senescent cells, which we can do at the moment, then we see an improvement in all tissue functions, and we see also a delay of the onset and and reduced severity of most disease that you can see here, suggesting that senescence at least is a common cause to multiple disease, and therefore it's a good target for both frailty and multimorbidity. And so for us, aging is a driver, but actually we think that aging is a risk factor. So it's not the only things that will lead to multimorbidity and frailty, but is a very important one. So the way we think about aging is in the same way you think about smoke for lung cancer. If you reduce smoking, you reduce your chances of lung cancer. In the same way, if you decelerate aging, you reduce your risk of multimorbidity and frailty in an important way. Many ways that we can decelerate aging. So we know that social deprivation, poor health practices, poor environment accelerate aging. So any policy in these streams will decelerate aging across the life course and therefore the chances of multimorbidity and frailty. But we also have now another tool, which is drugs targeting those mechanisms of aging. I told you that we are able to eliminate senescent cells. These are one of those drugs that we call geroprotectors. Specifically, we call them senolytics. And one such a drug is zoledronate. So this is a nitrogen-containing bisphosphonates, and they used for the treatment of osteoporosis. It is given once a year, so it's quite attractive in that way, and it is quite cheap. It's only £10 a shot. And but what you can see here is a retrospective analysis of women taking zoledronate. There is a considerable survival advantage. So this is cumulative incidence of death, and you can see that zoledronate has a reduction in incidence of death. But not only that, retrospective analysis also show, for example, decreased rate of infections, particularly pneumonia, and decreased cardiovascular events. In our work, we have demonstrated that it is interfering with important mechanism of longevity, particularly inhibits mTOR and require FOXO3A for its action, and basically reduce the accumulation of DNA damage. So what we wanted to show here was whether zoledronate was able to extend lifespan in Drosophila. We chose Drosophila for two reasons. One, because obviously live short, it has quite a short lifespan, so it's sort of easy to do the experiments. But most importantly, because we wanted to separate the effect of zoledronate on bone, which is the known action, from the one on aging. And Drosophila doesn't have proper bone structure; it's more cartilage structure. And therefore, when we gave zoledronate at middle age, you can see that here you have an extension of lifespan, which is more pronounced in female than male, but nevertheless is significant in both sexes. And if you can see here, the female is very similar to the one I showed you in the women with osteoporosis, where there is a lag time before you can actually see the beneficial effect. Of course, we were really interested in the ability of zoledronate to improve health span. And we looked at mobility and intestinal epithelial dysplasia as a sign of health span. Mobility is really important. It's one of the best predictors of mortality in actual fact. And you can see that in Drosophila, you have this reduction in mobility, which was attenuated by those which was, they were taking zoledronate. Similarly, with age in female flies, you see basically a disruption in the differentiation process of the intestinal progenitor cells. And they proliferate more, become bigger in size, and increase in number. And this is associated also with increased leakiness of the intestinal barrier. So if you look at the graph here, this is the quantitation of the number of cells in proliferation, and you can see that it increases with age. But actually, this is very much attenuated with zoledronate. And this is the number of positive cells, of these progenitor cells, which increase with age again, but this increase is attenuated by zoledronate. And this translates into how leaky is the intestinal barrier. So here you can see that by giving a blue dye to the flies, and they become blue, and you can count how many flies become blue. And you can see that this fly, the blue fly here in black, increase with age, but this is attenuated by zoledronate. And what we also showed here is that zoledronate can improve resistance to oxidative stress. So the extension of lifespan is probably due to increased resistance to oxidative stress. So here our flies have been treated with zoledronate, and then they've been given hydrogen peroxide. And you can see that those flies have an extension of lifespan compared to control, which are in black. And just as a side, we also had the rapamycin as a control, and you can see that the extension of lifespan seen with rapamycin is very similar to the one seen with zoledronate. So now we are taking this through the mouse pipeline to see whether there is an improvement across different organs in health span in mice, and then we will take the model of frailty and comorbidity. I want to spend a little bit of time looking at, what we are thinking in terms of clinical application to start with. We think that at this stage, we don't know enough about multimorbidity to establish a clinical trial in a very short period of time. And the reason for that is that, so at the moment, if you want to do a trial, because it's preventive, you have to get your population of people and then give the drugs and then wait, to see what they develop. And that would be too long to do. And that's what the TAME study is meant to do, and is meant to last 6 to 10 years. We think that would be costly and not practical, but we think that it will be feasible only once we know more about multimorbidity and have early biomarker that we can sort of quickly see whether there is an improvement. But frailty offers a great opportunity. So if we imagine frailty as an accumulation of deficits, you will have very few deficits when you're young, but you will have loads of reserve to respond to any adverse event, any damage. So if you fall, you fracture a femur, you will repair very quickly, and you will be out of hospital, actually not in hospital at all. But the more you age, the more deficit you accumulate, and the less reserve you have. And therefore, you reach a point where you don't have any more reserve. If you have a fall, if you fracture your femur, you will be in hospital for a very long time, and sometimes, unfortunately, you will pass away. So we think that if we can increase the resilient reserves at this stage before they completely exhaust their reserve, they will be more likely to respond positively to an adverse event, and therefore reducing the chance of staying in hospital for a very long period of time, or not recover, or lose their independence and end up in care homes. And really, the experiment has been done for us already in a way. This is a retrospective study. Patients on bisphosphonates, because they were osteoporotic, were admitted to ICU for a completely different reason. And those patients on bisphosphonate had a higher comorbidity index compared to the control group, and they were older. But despite all of that, there was a significant increase in their survival in comparison with the control group. And when you looked at the data, it shows that, for example, they have reduced their stay in hospital. So we think that this is really significant in terms of we can run a trial in a short period of time, but also have some real economic benefit. Days in hospital is what cost a lot of money, and also loss of independence, care, social care afterwards. So we think that here there is a very good. So in conclusion, I hope I show you the health span and lifespan can have different trajectory. That aging is a risk factor for multimobility and frailty. I would like really to stress that we don't want to hear that aging is a disease, because this is not scientifically accurate in the first place, but most importantly, it opens up important issues in relation to ageism that people have been fighting for a long time. And geroprotectors offer opportunity to improve care of patients with frailty in the first place, but with a bit more study about multimobility, probably we will get to multimobility as well. But we think that designing trials in pre-frail and frail patients with this drug can be an attractive proposition, can have impact in terms of health, quality of life, and cost, but most importantly, give us also an opportunity to learn how to run these type of trials, because at the moment we don't have many trials including frail patients, and we need to learn about inclusion, exclusion criteria, measure of outcomes, and so on. So we really hope to have this opportunity. And I hope I show you that Zolesuch is a new geroprotectors with great possibilities. So finally, I would like to acknowledge my group, particularly Genji Chan, who has done the work on Drosophila, and our collaborator, Martin Zeidler, Katia Slack, and Julia Cordero, and the Mouse Age group, which was a cost action with over 200 scientists from 25 different countries, some of which, that's where I met Dinko, so it was really good network. But I would like to particularly acknowledge these collaborators, because they really have helped driving the cost action to be a success. And thank you very much for listening.